Well, good morning, everybody. Welcome. It's nice to see you all, and thank you so much to Photo for inviting me to come speak. Can you all hear me? Yeah. Okay, great. Well, I am Nancy Rothenberg. I'm Vice President of PTPN, and I'm going to tell you what PTPN is in a second. But what I'm going to talk about is how we used Photo to obtain an outcomes bonus program with three of very large and three of our largest health plans in California, and how you can apply that and do some contracting of your own. So PTPN is a national network of therapists in private practice, physical, occupational, and speech therapists. We've been around for 28 years, and we have over 900 offices, private practices around the country, with about 3,000 therapists. And we have hundreds of managed care contracts on a local, some are statewide, and some are national. We do, besides managed care contracting, we do all kinds of stuff for our member offices. We do NCQA level and beyond credentialing. We have a quality assurance program. We sign contracts with preferred vendors so our members can save on supplies and equipment and services. We give them practice management, education, and expertise. We have a very robust political action program, the lobbyist in Washington, and we also have a cash pay health and wellness consumer brand called Physicality. We do lots of social media stuff, everything for our members. Excuse me. And we're currently in about 23 states, but we're also expanding into all 50 with something called PTPN Nexus. So if you're interested, and you're in a private practice and you're not in PTPN, we can talk to you later about getting you in. And I'm sure after this you'll be hot to go. PTPN has mandated the use of Photo for our members for about 6 years, as Al said. And what we require is 10 completed cases per quarter, which is beyond statistical significance according to Photo. So that's a fairly low rate, but that is the minimum. And in order to get that, I was listening to what Scott said earlier, and multiply the implementation issues from 32 to 900 offices, but the issues are the same. We've done lots of education for our members, lots of incentives. We've have marketing tools, we've had webinars, we give people awards, all kinds of stuff like that. And of course, we do nag. Call it compliance efforts, but it's nagging. A lot of times I feel like that's my job. I'm a professional nag. Some offices, were really enthusiastic from the beginning. They loved it. They were, been waiting all their lives for this program. They do hundreds and hundreds of cases a year. Most offices just said, yeah, okay, we'll go on faith. You're okay, sure, I'll go along with it. I don't really want to, but you're only making me do 40 a year, okay. And then of course we had those hard cases that we really had to nag. And we also had folks that said, I don't want to be in this network anymore if I have to do Photo, and we think they are misguided. All right, so PTPN, as we've been in our 26-year history, was ahead of the curve. Okay, we believe that outcomes data was the key to showing that PT was not a commodity, that therapy was not a commodity. I know that you go to any APTA conference and you ask the audience, you say, raise your hand if you don't do good therapy. No one will raise their hand. Now, I've been doing this for 26 years, and I'm pretty sure there are some people in that audience who should be raising their hand, okay? But they don't. That's what the payers think. They think PT is PT, it's just a commodity. I want to get it for the lowest price possible. We do not believe that. And we wanted to differentiate our network and the practices in our network by doing outcomes. And we believe that better outcomes should be rewarded. If you're doing a better job, you should be rewarded and get more money for that. And why? Why should you do that? Well, one thing, and Scott touched on this as well, it saves money in the long run. If you are rewarding those therapists who get patients better quicker, you're going to have fewer returning patients for therapy, for one thing, right? You're going to get the patient back to work more quickly. You're going to save on downstream costs, and Scott said that, you're going to save on drugs, you're going to save on hospitalizations, more doctor visits, all of which cost more than those few physical therapy visits we're talking about. And you're going to have more satisfied patients because they're getting better. They went to therapy and therapy worked. Now, it's one thing to be a visionary. It is another thing to achieve that vision. We needed to convince the health plans, well, we need to convince both parties, right? We needed to convince the health plans that measuring outcomes demonstrates value and improves care, and we needed to give the therapists a reward for their work and an incentive to continue. Because you can't just keep mandating something and telling people, oh yeah, this is going to be great, trust me, trust me, trust me, without actually giving them something tangible. And I don't know about you, but it's been my experience that it's increasingly difficult to get a raise out of health plans. Okay, maybe you all have fantastic luck, not so much here. I would call the health plans and I'd say, we haven't had a raise in 5 years, 7 years. How about a raise? And they'd say, yeah, that's very nice, but no. And so we had to come up with something else, right? Just asking for a raise because we hadn't had one in a while wasn't doing it. And so the first thing we did after we had gotten some good participation and data on the photo program is we created this thing called the PTPN Rehab Outcomes Index, or ROI. ROI, return on investment. See that little word play on? Yeah, okay. The ROI uses outcomes, quality assurance, credentialing, and patient satisfaction data. It lives on our website, ptpn.com, and it's blinded by office, so unless you know everybody's photo ID number, you're not going to know anybody else's results except yours. And we update it quarterly. When we get the new quarterly results from photo, we update it. And a picture is worth 1,000 words, so here's a picture. This is what our ROI looks like. And if you've ever looked at consumer reports to buy a car or a refrigerator or something, this will look familiar to you. We took that same scheme where the darker the bullet, the darker the better off you are. And so we have 5 different measures where you can be outstanding or above standard or below or poor, whatever. And then we have 2 that are above benchmark, at benchmark, or below benchmark. And so this made it a lot more easier to look at than to see an office at a glance. So we had the ROI, and then we started our discussions in August of 2010 with our 3 top health plans. Now I've underlined 2010 because I want you to remember that date. There's going to be a quiz later. Each step took months and lots of nagging. There's that nagging theme again. First was, hey, we have an outcomes program, let's do a webinar. No, really, I want to do a webinar. Come on, I want to show you what we're doing. And after they agreed to that, it was, well, outcomes are great. You can use it in all kinds of ways. Let's talk about the different ways that we could use outcomes together. And then by the way, while we're doing that, we'd like a raise, or we'd like an outcomes bonus program, because we're so, we're the only folks that are doing this. And the outcomes bonus program got some traction, and so then we had to spend time on the details of the agreement on how that bonus program was going to work and the contract language and everything. And so everything took months. Now, our first volley, right, was, hey, can we have a raise because we're doing outcomes? Nobody else is doing it. We're mandating that all our providers are doing it. How about rewarding us for that? And again, they said, yeah, that's very nice, but no. So we also, prior to that, actually before we had the ROI, a few years prior to that, we had tried to get a raise or an outcomes bonus program just on functional status change. Like, let's look at that and get something. No, that didn't work either. So we worked with that ROI report card that you saw, and we first looked at meeting certain benchmarks for certain periods of time. So there's 7 benchmarks on there, and we said, well, what if a practice met 5 out of the 7 for 3 out of the 4 quarters, and what if we did that? And they were like, yeah, yawns, crickets. That wasn't really getting it attention. And then one of the health plans said, well, can you tell me how your ROI relates to visits per case? And I went, well, that's a good question. How does it relate to visits per case? I don't know. Let me take a look. And bingo, that was the deal sealer right there. Once we looked at how the benchmarks related to visits per case. So here's that ROI again. We use these two, the outcomes benchmark and the efficiency benchmark. And let's talk about what those are for a second. First of all, they're true benchmarks, okay? They are theoretically attainable by any PTPN office. They're not an array. They're not, a percentile. There's not, because if you take offices and just, which is at the top and which is at the bottom, you always have to have winners and losers. And so no matter, even if everybody's at the 90th percentile, if you're only going to give a certain portion of that group a reward, the guy at 90 is not going to get one. And so we didn't want that. We wanted to have true benchmarks that could be attainable by anybody. And so what did we use? Well, our outcomes benchmark is the amount of functional status improvement, which is the residual FS score on your photo report. And we explain that to the health plans that it's the amount of functional improvement for your patients compared to that's expected on similar patients, and we talked about risk adjustment, which is very important. And our efficiency benchmark is the amount of functional improvement per visit, right? Also risk adjusted compared to the expected, and that's what photo calls utilization. So it's the utilization score on your photo report. So we just call them something else, but those are the two things that we used. And of course, the number of cases is important because we have offices that got fantastic, got up arrows for outcomes and efficiency, but they only did 4 cases. Okay, you don't want to reward somebody in a bonus program when they're only doing a small amount of cases. They have to at least meet the requirements, so that's important. Now again, it is our experience, and I would assume most of you around here, that health plans are historically fixated on visits, right? That's what they're fixated on. And in fact, when even just a few weeks ago, when you talk to health plans or payers about outcomes, a lot of them think you're talking about visits. They think that Mrs. Smith had 8 visits, Mr. Jones had 10 visits, Mrs. Smith had a better outcome. Okay, well, we know that's not the case. We don't know, maybe Mrs. Smith had 8 visits, but she didn't get any better, and maybe Mr. Jones had 10, but he got, he's up playing tennis again. And so we explain both to the providers and to the health plans that visits are just a portion of the efficiency benchmark, all right? And if you just have fewer visits than expected, that doesn't mean you're going to meet the benchmark, because you could have 3 visits, but the patient didn't improve, and that won't meet the benchmark. Or you could have had a lot of visits, 20 visits, but that was expected given the risk-adjusted factors for Mr. Smith, and the patient made a lot of progress, so you can still meet the benchmark. So it's quite a difference from a lot of other programs where, they give you 6 visits and that's what you get. All right, so what did it? Well, when we looked at offices as a group that exceeded our efficiency benchmark, that had the up arrow, and at least met the outcomes benchmark, meaning they had a solid dot or an up arrow, they had 1/3 less visits per case than those that didn't. Okay, so compared to the rest of the group, they had 1/3 less visits per case. And that saves the health plan money on a per patient basis, even if you pay the PTs more per visit. Okay, we can do them, it's easy math. If you can pay a therapist, 15, 20% more per visit, but if they're saving you 3, 4, 5 visits, you're still way ahead of the game. And so that was really the attention grabber for the health plans, as it should be. And I'm convinced that if the data had not demonstrated this, there would not have been the programs that we have today. So that was very important. So what did we get, you ask? Well, I'm going to tell you. I'm glad you asked. We got higher fee schedules for those offices that meet the criteria. We got 10% higher with Cigna, 12.5% higher with HealthNet, and 5% higher with Aetna. And you can see when up here or in your notes when these kicked in, right? 2012. When did I start talking to the health plans? This is the quiz part. 2010, right. It took 2 years. 2 years to get this done. Now, that's not to say that for you it would take 2 years. And in fact, right now we're talking to Blue Cross Blue Shield of Louisiana about a outcomes program, a bonus program, and it's not going to take that long. One of the reasons that it took 2 years was because we weren't quite sure where we were going. And so hopefully this presentation or working with photo, you can get a better idea. But it does, I like to say that these entities move at the speed of health plans, which is very slow, right? But what did we get? So we got the higher fee schedules. We definitely got differentiation in the marketplace because nobody else is doing this. And we got a closer relationship with the health plans, which is very important because, just like your competitors, our competitors, of course, are always knocking on their door as well. So how can this translate to a single office or a group of offices? I don't know what kind of, you may have, more than one location or whatever. How can you use this information? Well, if you are talking to a local employer or a medical group or IPA or a case manager or a local ACO, ACOs are very, that they're very interested in this because they're, have to measure quality. You want to use your photo data to show your results. Now, you don't, well, I'll talk about that in a second. So the best thing to start with, I think, is your 12-month scorecard. And you want to look at your utilization and your effectiveness and your efficiency, which is what photo calls it. And if you're a PTPN member, I know there's a few of you out there, you can use your ROI scores in addition to or instead of the photo report. And here's your scorecard, right? You should all be familiar with this, hopefully. This is what you see when you go on the photo site. And the utilization info, it's kind of fuzzy, hard to see from back there, but so I won't go into the numbers. This is an actual office. I changed the name to protect the good office. But they have about half of their patients for all orthopedic in the green there in the high, doing better than expected. So that's a really good score. Their effectiveness, they're doing about they're about 2 more points of change than predicted. And their efficiency is about 3 less visits. So that's good, some really good results right there. But if your scorecard isn't great for the 12 months, because remember, scorecards are on a rolling 12-month period, because so maybe you were sort of weaker in the beginning of the 12 months and better at the end, then you can look at your outcomes profile report, because that has quarterly data, and you may have some better quarters than others. But whatever you do, you don't want to hand, this is what we tell the offices not to do to physicians, and I'm sure we're going to hear about physician marketing and she'll back me up on this. You don't really want to hand them your photo reports, and I don't want to hand health plans or case managers your photo reports. You want to translate that data into something that's an easier to understand format. And again, if you're a PTPN member, we have on our website ways to take the photo data and put it into something that makes a graph that makes it a little easier to understand. And these are your profile reports if you don't know what I'm referring to. So how can you do this? Well, your results obviously have to be good. You can try, I heard Scott say, and people have tried to get more attention just because you are doing outcomes, which works sometimes, but it's better if your results are good. If your overall result isn't where you want it to be, right, your all patients or your all orthopedic patients isn't that great, you can look at different things. Like you can look by condition, body part, patient type. Maybe you do really well with HMO patients or workers' comp patients. A particular physician's patients may do really well. You may have certain therapists. If you have more than one therapist in your office, there may be a certain therapist patients that do better than another. And I'm sure photo is really good. I know especially Trish has done this for some of our folks, to look into your data and pick out the jewels, right? Pick out what you want to tout to whomever you're talking to. And when you talk to them, whoever the them is, You want to, I think the first 3 things are very important on this list. Third-party measurement and comparison to a huge database. You know, among the hard cases, or what did you say, the special needs office that Scott talked about, you know, they'll say, well, you know, I'm doing outcomes. Okay, well, what are you doing? Well, you know, I have an oswestry or I have a dash and I fill that out and then I put it in the file. Okay, you know, that's nice, but that doesn't tell you anything. It tells you something, but it doesn't tell you how you compare with everybody else. And so when we, you know, talk to the health plans or the, you know, self-insured employers, we say, first of all, this is going to a third party. We're not monkeying with the data, right? Data doesn't even come to PTPN first. It gets sent to Photo. Photo gives us the results. We have to take what we get. And then it's comparing not just our offices to our offices, because there, you know, are other groups or whatever that can do that. It's comparing it to the larger universe out there. And the thing that really gets attention is a third thing, which is the risk adjustment. A lot of the progress we made was when we finally got to talk to the medical directors. And the medical directors are it's one of the first things they ask is about risk adjustment. They understand that. You know, the contracting folks are fixated on the visits. Well, let's give everybody 6 visits. But the medical directors are quite impressed when you talk to them about the risk-adjusted issues in Photo. And then, of course, you know, you talk about your utilization score, meaning you're getting the patients better faster. And of course, claims data, as we just talked about, cannot tell you if the patient got better. And having fewer visits, we hammer this home too, does not necessarily save costs, because more doctor visits, more drugs, more surgery. Disgruntled patients and especially injured workers, okay? Self-insured employers are also, besides medical directors, self-insured employers are also very interested in this, and those are self-insured for workers' comp. And when you talk about, you know, the patient's actually going to get better and, you know, get enough therapy that they need, that's a selling point, because disgruntled injured workers become litigious, right? They hire attorneys, and the employers want to reasonably avoid that eventuality, so that this is a good selling point for that. And of course, talking to them about returning to work more quickly or more slowly. All right, and do not forget the 3 most important rules. Follow up, follow up, follow up. And of course, don't forget to follow up. This gets back to the nagging theme. You know, this is not important for them, it's important for you. And if I had just said, oh, hey, we have this outcomes program, let me know when you want to talk about it, I would not be standing up here today. It was a lot of emails and phone calls, and when should I call you again? And you know, it's a real marketing push to get folks' attention and push them along in each step. So if you don't get anything, you know, the first time, you got to keep on trying. So you want to continue to run the numbers. Each quarter I continue to run our numbers, and the data has stayed true to the original. It fluctuates anywhere from the group at the top having anywhere from 25% to about 1/3 less visits than the rest of the group. But you also want to continue to run your numbers, because if you don't look good now, you may later. And again, you want to remember that the SCORECARD data is for a rolling 12-month period. So what was the payoff for PTPN? Well, we were right. There was a reason to do outcomes. Always nice to be right. That's, you know, that's always good. And we rewarded existing members for their efforts and for ours in compliance, which also felt very good to get those folks more money. We got mostly good feedback from our members. Did not get 100% good feedback. If I ever get 100% good feedback on anything, I will do it twice. But mostly we did get good feedback on this program. We got better relationships with the payers, which is quite important. And again, all offices can attain the benchmarks, so theoretically all could eventually get the higher fee schedules. And in fact, I just ran the numbers a few weeks ago. Since Cigna became effective May 1 of 2012, May 1 this year is when we will do the next round, meaning we'll look at it again to see who qualifies, and I had to run the numbers so they could get it implemented. And we had 20% more offices qualifying for the Cigna bonus this year than qualified last year. So that was really nice to see. It continues to differentiate us in the marketplace. We generated a lot more interest in photo compliance, and we generated a lot more photo participation and raised our network's overall scores. California, and again, this is in California, we've been doing this. After this program went into effect, we beat, for the first time, we beat photo averages on functional status and visit data in every category except workers' comp. And we've continued to do that. And that, I do not think, is a coincidence. I think when you give people incentives, that's why they're called incentives, they do it. And in fact, I have had, since we've been telling our members that the new calculations are coming up, we're doing the next few months for these 3 plans, I have had folks call very interested in, did they make it? And if they didn't, why didn't they? And where are they? And so I've looked in depth at some of these offices and their trends, and their trend, even if they didn't make it for Cigna, they are trending up. Their functional status and their efficiency scores are getting better. So that's quite lovely. So that's it. That's where I am. Questions?
I have one over here.
Yes.
So the landscape's changing. We're moving to ACOs, bundled payments, those types of things. So I think as a profession, at least for us physical therapists, I think it behooves us to move away from visits, because that's not going to really matter. They're giving you a lump sum. I think our outcome, how good our outcome, and then less utilization of the rest of the healthcare system is going to become more important. Have you come across that at all, speaking with these payers yet?
Repeat the question. Okay. The question is, it was talking about how the healthcare landscape is changing, and bundled payments are part of what's coming up, and have we encountered folks asking for bundled payments? Is that
well, have you noticed that they don't care about visits as much, and they're going to start caring more about the outcome, because then they'll use less MRIs, less injections, less surgery?
Well, I think with healthcare reform and and with ACOs and all that, that has certainly helped us get more traction when we talk to entities about outcomes. And we have, our marketing folks have targeted the ACOs because they are quite interested in the outcomes, because they have to be. That's part of their whole thing. So I think it's, the environment makes it easier than it was previously, and maybe that's another reason why it took 2 years for this to happen. Specifically bundled payments, we haven't seen that yet. Other questions? Yeah.
So when that happens, will you be able to change your algorithm to include the downstream saving costs so that gets bundled into that payment, so it's not just episodic, but it's downstream savings too?
I would love for photo. She asked me if we can bundle in the downstream costs. We would love to be able to show that. We don't have that data. The health plans have that data. And so, one of the things that would be fabulous to do would be like a pilot program where you look at, the offices that have good outcomes, or the patients that have good outcomes, how much downstream cost did they use, and the ones that didn't. Our folks have been asking, can't photo get us that data? So I'll repeat that request. But yeah, that would be lovely. We just don't, since we're only in the therapy piece, we don't have that data. Yes, ma'am.
When you're negotiating with a single insurer, let's say like Cigna, does Cigna care that the data that you're presenting to them may include Medicare, may include United Healthcare? Do they want to know just what's the information for their participants? That's one question. And then the second one is, do they care about what your percentage of their clients are participating in this photo? In other words, are they looking at cherry picking?
Right. That's an excellent question. The question was, when we're talking to the health plans, do they care that the data we're giving them is on the aggregate patients for an office and not just like the Cigna patients if we're talking to Cigna? And do they ask about, opt-outs or cherry picking? The last one's easy. No one's asked us about cherry picking. I don't think we show them how the software works and whatever. I don't think they're quite sophisticated enough to think about cherry picking, although believe me, the PTs have asked us that question repeatedly. But Aetna just recently asked me if we could look and see if there was enough data just on their patients, because right now we're doing it from our ROI, which is all the patients. And I said, well, we don't, I looked, Photo looked for us, and we didn't have a statistically significant data set of just Aetna patients. And I explained to them because, how this works. And, if there was a bigger incentive, or you paid, per patient instead of in the aggregate, we could certainly work something out. And one of the things that we had been talking to Blue Cross Blue Shield about in Louisiana is just doing it on their patients and doing it in a different way than this is. And I've recently been working up some models on that. We actually get some we can get additional data from Photo that we hadn't been able to get when we designed these. That will make that easier. So we're have a set of proposals on our tool belt now to do that. The reaction that I expected and that I think we've gotten from Blue Cross Blue Shield is if you want to do it that way and pay like a bonus per patient that meets certain criteria and it's your patients, you have to do more work, you the health plan, because you have to validate that these are your patients and how many visits they had and all that kind of thing. So that would make the health plan a lot more invested, and they would have to see whether they want to do that kind of work. Any other questions? Nope. All right. Thank you.